We're going to try to keep to the schedule and get started with this next session. I'm Bruce Gellin. I'm at Georgetown University Medical School, where I'm a senior advisor to the Georgetown's Global Health Institute, and I'm an affiliate with Rebecca Katz's Center on Global Health Science and Security. As Jesse mentioned at the beginning, I spent quite a while at HHS at the National Vaccine Program Office, where the goal is to try to coordinate the range of federal activities and vaccines and vaccinations. And probably what I said maybe once a day, maybe more often, was there's a vaccine world and a vaccination world, and there's not really an arrow that connects the two. So moving on for this session is really to talk about the vaccination side of this. And we've got four great expert panelists, and you'll all remember in the pre-Zoom era, an expert was somebody who came from more than 50 miles with slides. We don't have any slides, and nobody's traveled, but we still have a great panel of experts. I want to start with Hanna Nohynek, and you already had a preview of that with her discussion with Marco, and to tell us about sort of how Finland went through this, looking at the epidemiologic situation and the considerations they had on what they were going to do with vaccine to a vaccination program. Hannah's got a long bio that you've seen, but she's among her many things is that she is at the chief physician in the unit of preventive health and threats in the Department of Public Health, which is their government public health research agency, and she's currently the chair of WHO SAGE. Hanna, over to you.
Thanks a lot, Bruce, and hello to everybody. We in Finland, we had the avian influenza outbreak in June 2023. There were lots of wild birds that fell ill and died. And then they spread the infection to our mink farms. We have hundreds of mink farms, especially in western part of Finland, and that livelihood is actually protected by our constitution. So even if us in public health have been saying already for years that the mink farming should stop, the livelihood is still ongoing. Actually, today in our parliament, they were discussing again whether there should be a new law to stop the mink farming. Let's see what happens. But anyhow, in 2023, then we had infected fur animals, mostly minks and foxes, from over 70 farms. And there were about 500 human exposures to these infected animals or dead animals. But through serology, none of those people, whether they had symptoms or not, were seropositive. So luckily, there was no spillover of the infection. In that situation, however, the thinking was that because the epidemic was really ranging from one farm to another and from animal to another, we thought that it's of our utmost responsibility to protect the mink farmers, the veterinarians, the bird ringers, the laboratory workers, the waste managers who come into contact with these possibly infected animals. And we were in negotiations with the European Union, which during that time was negotiating with the manufacturer that Marco shared the data on the Securus on obtaining their vaccine. There's a joint procurement by the European Union, and 14 countries actually went into that joint procurement. And so we were waiting for the vaccine to become available. We were ready to start vaccinating already in fall 2023. However, the regulatory process took quite long, and the vaccine became available only in June 2024. So I told you the target groups, and we made the vaccine available through the health care facilities and the well-being districts. And now when we have looked into the uptake, it has not been very good. I mean, it's only been about 5% of the target group that has taken up the vaccine. And we're in the process of interviewing them on why or why not they have not taken the vaccine. My own thinking is that because other countries have not started vaccinating, because the vaccine did not go through clinical testing, only preclinical testing, and because the epidemic is not raging in Finland anymore. I mean, the last wild bird that was found infected was in January 2024. So it's like the situation has pacified. However, we would want to continue with the vaccination before the spring migration of birds start next March. And we're waiting for the results of this survey on why people are not taking the vaccine, if we can better approach them and reach them through their associations and through their public health nurses in those districts. Along with the vaccine campaigning and vaccination, we're also doing an immunogenicity safety study. And this is with a sample size on 300 with 2 cohorts. The first cohort is people who have not received any avian influenza vaccine beforehand. And then the second cohort is people, mostly lab workers, who already in 2009 and 2011 actually did receive a avian influenza vaccine. And so we will be looking into both antibodies and cellular immunity to answer the questions on how immunogenic this vaccine right now is in naive people, as well as in people that have been primed before with avian influenza vaccine. Of course, among those, we also have people that have received seasonal influenza vaccine, so we'll be able to tease out hopefully also on whether there is any cross protection from the seasonal influenza vaccine and whether that modifies the immune response. So that's, Bruce, basically where we are right now, and we haven't given up hope, but I have to say that it's a somewhat of a difficult situation here where the target group clearly doesn't seem to be as motivated as we are here in the Public Health Institute. Over to you.
Hanna, thanks. We'll get back to you about what advice you have for us as we move into that. So I want to turn next to Kelly Moore. Kelly is the president and CEO of immunization.org and is an adjunct associate professor at Vanderbilt University School of Medicine. She also ran the Tennessee's immunization program for over a decade and was an ACIP voting member. So there are a lot of hats that Kelly has, and give us her perspective on where we are now and what we should be doing to get ready.
Thanks, Bruce. I think, I'm really intrigued with Hanna's experience in Finland. I think there's an opportunity right now for ACIP to begin public conversations about what a comparable occupational vaccination program may look like in the US. And we certainly saw there's a precedent for special meetings. So we don't necessarily have to wait for the next regularly scheduled meeting to have these kinds of conversations. And I think what's really important about the ACIP is that that is the public forum where we transparently talk about the available data. We have questions and answers asked in a public setting, and anyone who wants to listen in can do so. And I think that one of the lessons learned is the importance of transparency, of realistic expectations, and making sure that everyone involved is hearing the conversations and on board with how we're making the decisions that we are. Now, with respect to vaccination programs, which you're exactly right, implementation, it takes into account a lot of things that are not nearly as intriguing and scientific as what goes on in the research arena. But there are critical issues that we could go ahead and address now based on what we've learned from the last 5 years and actually 2 federal vaccination programs. We had COVID and worked through state immunization programs and state public health, as well as local public health in the commercial sector, to deliver vaccines to the public that many people are familiar with. But we also had a smaller program with Mpox, where we took a stockpiled vaccine and delivered that to target affected populations. And there's no reason we need to wait to address logistical issues that did not go well in those 2 different scenarios. What we might face with an occupational H5 vaccination program would look more like Mpox, and of course, a pandemic program more like COVID. But these operational issues are consistent no matter what pathogen we're dealing with. So some of the things that immunization programs are dealing with is what software packages they're going to use, how to do the vaccine ordering, how to do shipping, how many shipping locations each state gets and where we're able to send them, how to transport vaccine if we need to, inventory management, dose reporting through immunization information systems, federal vaccine provider agreements that stipulate how the vaccine can be used by a private individual who is working on behalf of the government to deliver vaccine, mechanisms for rapid deployment of supplemental federal funding, simple standard contracting mechanisms for vaccination teams who are likely going to be going on site to deliver vaccinations, and payment mechanisms. And those issues are pathogen agnostic, but they don't need to wait to be fixed because they can make or break the delivery of these vaccines. And I will urge that when possible, using existing vaccination program infrastructure is really important. Very quickly, a couple of other things to focus on: organizing now and defining roles and leadership for a potential occupational H5 vaccine rollout at the state or local level. And it's critical that the folks who are working in immunization programs, the program managers in every state whose operational knowledge is essential for practical planning, be at the table during these preliminary discussions. There's no reason to wait to begin to educate public health on what we are thinking, what we're looking for, what we might do, and why. States and local public health officials have after action reports based on impacts in COVID. They need to dust those off, look at what needed to be fixed back then that they were too tired to fix, and go ahead and fix those things now. Finally, we have invested in relationships with community-based organizations who have relationships in rural health and in extension services with the affected populations. We need to go ahead and be leveraging those, investing in those relationships, because anticipatory guidance has been proven to inoculate the public against misinformation later, and we need to bring people on board now before we're asking them to make a decision. Back to you.
Great, thanks. And that tees up Glen quite well, actually. So Glen Nowak is Professor, Associate Dean for Research and Graduate Studies and co-director of the Grady College Center for Health and Risk Communication at the Grady College of Journalism and Mass Communication at the University of Georgia. And as, or probably more importantly for this audience, he spent 14 years at CDC, including 6 years as the Director of Communications for their immunization program. Glen, we've all learned that communication is probably the most important tool that we have in all this. So what do we need to be doing to make sure that tool is ready?
Well, you're absolutely right. Right in terms of this follows Hanna and Kelly's remarks quite well. So I also spent 6 years as Director of Media Relations at CDC, and that's relevant because I was there during the 2009-2010 pandemic. And I think my experiences have taught me a number of things when it comes to flu and pandemics. And I think one of the first things that I've often found is that a lot of money is invested in research and development of vaccines, but very little is spent on trying to understand how to get those vaccines accepted. So we don't do a lot in terms of understanding the barriers and facilitators of vaccination. And Hanna touched upon one of the key essential elements, which is spending time talking to the people for whom the vaccines are going to be recommended. Because we know from our experiences with recommended childhood vaccines, recommended adult vaccines, that there are barriers and facilitators to vaccines. And they include people's misperceptions, lack of knowledge, lack of understanding about the diseases, about the vaccines. So I think one of the most essential things right now is making investments in community engagement, communications research that will help us understand what are going to be the perceptions, the beliefs that we're going to have to address and overcome if we're going to get people to accept a vaccination recommendation. And that includes looking at some of the lessons we learned from COVID. I think when we look back at COVID, there are some clear things that turned out to be massive struggles on the communication side. When we started adding recommendations for vaccines, for vaccination, for additional vaccinations, and getting caught up in language, right? Is this a booster or is it not? And those are, issues that get us concerned, but the people for whom vaccines are recommended, that's not how they think. They want to know, am I going to benefit from this vaccination and how? We started, I think, with COVID vaccines fairly strongly in pointing out that these vaccines were authorized and licensed to prevent serious illness, including hospitalizations and death. And that's kind of slipped away from us on the messaging front. And we started creating messages that suggested very strongly that if you got a COVID vaccination, you would be protected from being infected. And so I think among the things that we have to figure out on the communication side is what are the core messages going to be about these vaccines and what they can do and what they can't do? Because at the end of the day, communications to be effective is mostly about setting and guiding appropriate expectations. And we fail when we set expectations or we don't that we set expectations that we can't meet, or we fail to deliver on our promises. But right now, I think that the key things are looking at what have we learned from our COVID experience, that where the hurdles came in, where the challenges came in, where the reluctance and hesitancy came in when it came to our recommendations, and are there things that we need to do differently on the communications front or the community engagement front to overcome those challenges? What kinds of messages are going to be most effective in terms of facilitating understanding of why we're recommending these vaccines, particularly for the first people that we're going to be recommending them for? What are we going to tell people about the different formulations and types of vaccines so that that builds confidence rather than skepticism and concerns? And when are we going to start making those investments, and where are those investments going to come from, so that we can do better communications and better community engagement going forward?
Great, thanks. Lots of food for thought. So next, I'm going to turn to Josh, and we're going to have an open conversation among us. Josh Sharfstein is Vice Dean for Public Health Practice and Community Engagement at Hopkins. Also brings a lot of other experience here as a Principal Deputy Commissioner at the FDA and as the Health Commissioner of Baltimore and some time on the Hill, and has a book that is called Public Health in Crisis. So there's a lot here that Josh can bring here. I want to hear from you, Josh, about where you think we are and what we need to be doing.
Sure. Thanks, Bruce. It's great to be here, and I really appreciate the other presentations on this panel. It's nice to be in a space where I think we all have the same goals and basic understanding of the potential value of a vaccine for a really potentially catastrophic scenario. I think I'm going to be the person on the panel that points out that we're not necessarily in a position to assume that everyone has those basic starting points. In fact, we have a potential nominee to be the HHS secretary who has made a career of not being truthful about vaccines and opposing their use, including the influenza vaccine. And I think if it's okay with you, Bruce, I would just make a few thoughts about that, dragging us back into the reality of the newspaper headlines of this week. I think, number one, with some degree of understatement, I could say the federal government might not be there as expected if things get to a problematic point. It could be actually the case that the federal government, either through changes to ACIP, which I completely agree can play a vital role if done well, or through interference with the FDA, could actually make it quite hard to effectively even get the United States to the starting gate for vaccines. I mean, that is the scenario that we all have to contemplate, and that may be one scenario. You have another scenario where the bare minimum happens, but in fact, what you get are appointees and others potentially talking down the vaccine, doing almost the exact opposite of what a communications campaign would attempt to do, and directly undermining it from kind of inside the house. That is not at all an unrealistic scenario either. And I think those two scenarios we have to confront, we have to think about them, and we have to prepare for them. For the first one, I think that there's certain things that only the government can do. And if the government fails to do that, then it's denying anybody the choice of getting a vaccine that could be very valuable, not only to them, but to the rest of the country. And in my mind, that requires a lot of education of the public about what's at stake, a lot of work with journalists, and a lot of intensive pressure on the federal government at every possible level to get them to take a concern like H5N1 seriously and to do the basics. But I would also say that almost certainly, even if we're able to get the federal government to do that, there's going to need to be an extra federal government effort that really dwarfs anything that's happened before. I think we're going to have to assume that it's going to be very, very hard for the federal government to provide effective leadership. And that's going to mean even if the vaccines become available, that we're going to have to think about some kind of governance structure that involves a lot of state leadership, local leadership, and experts who are involved, and others. Could be people who are trusted by the American public for other reasons, who are able to pull that together and lead a parallel, approach to getting people to understand what's going on and be a source of truth that may not be what the federal government is able to provide. And that's a really hard thing to contemplate, but I think it's worth it for people who care about, people not dying from preventable illness, and for everything that you all are talking about, for vaccines to be deployed effectively, for us to think about what that would look like. Could it be, under the auspices of the national academies? Could it be under the auspices of a new kind of consortium that would come together? And that way, the states and locals could get really good advice, could be participating, could be showing leadership. We do have a lot of great leaders for health around the country who could be playing a role. And unfortunately, our federal government and its ability to lead may really be hampered and instead will turn into a headwind. So, Bruce, that's what's on my mind this morning, November 15th, 2024. I hope that, we wind up back in the world that we think would be most effective. But if we're not, we will be fighting two battles, one against a actual virus and one against a kind of the plague of misinformation and falsehoods that would be coming from positions of authority.
So Jesse and Norman and I began working on this a long time ago, and we didn't plan the timing of this to be now, but Josh, thank you for giving this reality testing. But I actually start with you and maybe to others, but given that, I was at a talk yesterday with Atul Gawande, said he had 68 days left. So I assume there's 67 days left. What could the current crowd do in those 67 days to shore things up? Josh, I'll start to you, and if any others have suggestions, go ahead.
Well, I would say a couple things real quick. One, obviously have a clear playbook and release it if possible, so people know what CDC is thinking of doing and would like to do, and that could be a basis for lobbying. The other thing that I think is really an advocacy, I should say, the other thing that I think is really important is for people at CDC and for people outside CDC to understand the legal basis that CDC operates on and FDA operates on. That it's not the case that a political appointee gets to decide everything to do. I know that as a former political appointee at FDA. The law requires FDA to do certain things. The funding that CDC gets requires CDC to do certain things and follow the science. There are clear standards for advisory committees, and really making that clear. So if and when there are attempts to interfere with that, they can be spotted very carefully and very, very quickly. And so I think that both having the playbook, but also making clear that, regardless of who's sitting as the HHS secretary, the people who work at FDA have obligations under the law that they have to follow. They are obligated to, take certain actions and pursue the public health mission of the agency. And that's what we all still need to expect them to do and support them in doing. So
maybe Glen and Kelly, if you've mentioned some general pieces, but are there any specifics that you would put in the 67-day plan? And then Hanna, over to you to try to get a sense of how all this stuff going on here is affecting the rest of the world, which you now represent.
Bruce, I'll start by saying, the ACIP charter now says that there can be 19 members of the ACIP. We're currently at about 15. There was an update to the charter. I would say one easy thing to do right now is fill every seat. Make sure that you've got appointments in place. in the next 2 months with appropriate people. That would be a help. That's very specific. Also, there's no reason that we can't call a special ACIP meeting if the CDC director so chooses to have conversation so that the public is hearing accurate information now about what we're considering. I think there was a hesitancy perhaps before the election to bring up conversations about things that might raise the specter of a future pandemic. But I think now is the time to start getting good information to the public more broadly to inoculate them against the misinformation they may hear later.
Yeah, I don't know that 67 days is going to help you establish trust and commitment from a large part of the U.S. population. So, but I think it's recognizing that a large part of the U.S. population doesn't understand, as Josh was saying, the importance of these institutions and their functions. And I think they're, unfortunately, in some cases, may find out what they're doing that they were unaware of. But I think it's also recognizing that, you know, what people are wanting is they don't want social and economic disruption, and they want to have access to healthcare. And if a pandemic happens and you're not prepared and you aren't smart and strategic about your response, your likelihood of doing damage on all three of those fronts is much higher than it otherwise would be. And so that there are major downside consequences to just taking a haphazard ad hoc approach to these things.
Thanks. Hanna, your thoughts about how is all this rippling across the world and affecting you in Europe?
Well, last week I was in the WHO European office in Copenhagen when the results of the voting came out, and there were several CDC seconded technical experts in the room. And, you know, we were ready to open champagne bottles, but of course we did not. I mean, instead I gave some mushrooms that I had picked, and they just asked me that I hope that these are not poisonous mushrooms. Seriously taken, I think all of our concern is that CDC is such a major player in the world health through secondments, through scientific work, systematic reviews you do, the ACIP, which is an open meeting that all the NITAGs in the world and RITAGs in the world can watch and learn. We are really worried, and countries that are very reliant on the CDC secondments and technical expertise will start feeling it, that they will not have that level of expertise in their countries, and where will they then build this expertise for their own benefit is a big question mark. So I mean, that's one worry. The other worry is, of course, pulling out from the climate pact and pulling out from other collaborative work with low middle income countries. So it really is a major concern. Yes.
Thanks. Glenn, you remind us that we won't solve the trust problem in the next 67 days, but it's a long-term problem, and it's going to continue to be one unless we start to work on it. Again, I'll start with you, but to others, your thoughts about what to begin to do to try to improve the trust that people have in the system, from the system that creates vaccines, that approves vaccines, that recommends vaccines.
Well, I think it's going to be starting with community engagement, starting with the engagement of people who are going to be either recommending vaccines or people who are going to be a high priority for receiving vaccines, to better understand their concerns and how, more importantly, what their health decision-making processes look like. How do they make their decisions about health? I think it's going to probably result, I think we need to have better communications research methods. I think sometimes we rely on just asking people survey questions or asking people some straightforward questions. Why did you do something? Why did you not do something? I think some work we've been doing at the University of Georgia with AR, augmented reality and virtual reality, as a way to kind of give people an experience that makes them better able to tell you what they would do, because oftentimes we're asking them to imagine what they would do. And I think we've got communications technologies that can actually illustrate much better and bring things to life. And we can probably get better answers in terms of why do they believe what they believe and find better messages. So I think working on improving our communications research, the methods that we use to better understand audiences, and making a concerted effort to understand and put their interests at the top of our list.
I would echo that and say that, one thing I learned during the anthrax response that as a first-year epidemic intelligence service officer is when you don't know something, say so. Don't overpromise. And I think there's a temptation to want to reassure people by being overconfident to convince them to take something. But then when the reality is they understand that we don't know everything, that can ultimately increase a lack of trust. So I think not overpromising, being realistic, and respecting the intelligence of the public to be frank with them when we don't know things, and the learning process we're going through ourselves is important.
Let's get back to the more specifics of.
Bruce, can I just jump
Go
in
ahead.
real
Please go
fast
ahead.
and just say that I certainly agree with all those things. I would add that a critical issue is the vitality of local public health. During the COVID pandemic, a lot of state and local health officers could do is hire basically remote call centers to call people, and remind people of things or check on things. But there are some local health departments that were really able to hire people from within the community to go out, go door to door, meet with people, and do really critical work. That is, I think, where you have a much better chance at trust than just sending in, messages on high. And if you don't have a viable local health department, it's extraordinarily difficult. And so, this is going to fall to Congress to continue to provide resources for local public health, match with expectations. I think the Commonwealth Fund Commission on the National Public Health System has like a vision for that. But I think we are fooling ourselves if we think we can, just do one-off solutions without the fundamental infrastructure that is, I think, well, its absence and its weakening over the last few decades really has played a very important role in the development of and the opening for all people who, really are on a very different page than ourselves.
Josh, and your title is community engagement. So beyond public health, how does the community play into this?
Well, I think public health has a very important role in working deeply with communities that are in their area, and that can take the form of public health agencies hiring from communities, like happened in Baltimore for the vaccine corps. Baltimore had one of the highest rates of vaccination of similarly situated counties in the country. I think it was like top 3% when we looked at it. And, there were people from Baltimore communities with low vaccination rates hired to go door to door and talk to their neighbors. There were all kinds of community organizations that were organized as part of, different campaigns. And, I remember the NAACP chapter having a mobile information effort around vaccines. There was just a lot of different types of efforts that were loosely coordinated by the health department, with the health department really providing key information. And I think like those kinds of things, those are the kinds of things that actually did recover a lot of vaccination in different communities during the pandemic when they were able to be funded around the country. So I think it's both the organizations doing the work, the health department opening the doors to people to come in and play roles within the health department, and a combined effort really to point out that a lot of the misinformation is coming from outside with people with vested interests. Maybe the one thing, I'll just ruefully say that, like, in the past, the anti-vaccine groups have said, here's the one thing they don't want you to know. That's kind of like the message. In the future, it may be us with that advantage saying, if there is an administration or a senior political leader who is not telling the truth, that, the idea that we have to look at actual information, and this is the one thing they don't want you to know, that kind of argument may be on the side of community organizations who really want people to take care of themselves and protect themselves.
Nice. So back to the specific of H5, Kelly, if I have this right, and you'll correct me, and when in our pre-call you mentioned that you talked about your experience, but among them was that you're a farmer's daughter of a cattle ranch. I have that right. So I guess the question is back to that and channeling Hannah's comments about the uptake there among, not the exact same community, but people who aren't really as used to this. What do you think we need to be thinking about as far as the people who are at high risk on the farms?
Yes, I'm very proud farmer's daughter from Alabama. And so we raise beef cattle, not dairy cattle. So it's a very different type of operation. But what I can say is that it's so important to get to know these communities, not to make assumptions about them. I think, it's so easy in a large country to imagine what other people's lives are like. But I think there's no reason to delay connecting with extension services, rural health programs, and others who understand the dairy community and the poultry community. Because while poultry farmers are very familiar with avian influenza and the risks and biosecurity, this is all brand new in the dairy industry. And what we're thinking about at the high levels is, how do we prevent reassortment? How do we prevent adaptation to humans? But we can be working with dairy workers today, dairy farmers today, understanding their concerns and listening locally. I think Josh was exactly right. We've got to continue to invest in local public health and in local community-based organizations and resource them to help bridge the gap now, so that we can listen to what their concerns are and prepare them. So before we are asking them to make a decision about a vaccine, they need to understand what's going on, so that when we do offer it, they understand we're trying to help them make a well-informed choice about vaccination. And I think that's something really important we need to dispel right out of the gate. Nobody's coming along and forcing anyone to do anything. I think that we learned clearly from COVID, even the fear of mandatory vaccination is enough to push people away. So we can start addressing those issues now locally and listening to their concerns, meeting them where they are.
Glenn, is there a soundbite for how to prevent reassortance and why that's going to help increase people's uptake of vaccines?
Well, I think, I would say that people want access to healthcare. And I think we saw during COVID that one of the things that did get people who may otherwise have been reluctant is they could get very sick and they wouldn't have access, or they didn't have COVID and couldn't get access for their cancer treatment, for the other things. And so I think reminding people of, that's why we try to prevent these things, because we don't want to have people not be able to get needed healthcare. I think the other thing I would say is, I think I would, we often rely on the word science. I think the better terms are evidence and proof. And I think challenging the people who are coming in with their ideas using the same strategies they did to challenge us is, where's their evidence? What's the quality of it? Where's their proof that the things that they're advocating work? And I think we need to start doing some of that back to them as well.
Right. So we need to wrap this session. One of the things we wanted to get out of it was the couple of things that each of you wanted to recommend to whoever was going to be listening to that. We didn't think it was going to be the next crowd, but that's among them. You had some great specific recommendations. We'll go around one last round if there are additional things you want to say at this point about things that need to be happening now to try to get us further advanced should we actually need to use a vaccine. Maybe Hanna, I'll start with you.
Well, maybe you can take our lessons, and maybe we did not do our kind of community search and all the concerns into consideration as much as we could have. So I really agree that that's important, but also realizing things change. I mean, we were ready to start vaccinating and we were being asked for vaccines in fall 2023, and now the situation is very, very different. So it's a dynamic field.
Okay. Kelly?
I would say keep investing. The Congress needs to understand they need to keep investing in our public health infrastructure. Don't dismantle what we've built, including surveillance and new vaccines and treatments, and focus on a comprehensive approach, not just a piecemeal approach to these threats.
Glenn?
I would say we have to engage with local and state policymakers and elected officials, because they're going to be the frontline people. Health departments are going to be affected, and understanding their concerns and what will help them.
Josh, you get the last word or words?
I would just say I really appreciate this discussion. There are a lot of things that can be done. And I think we just have to not be knocked too far back on our heels before we recognize that people really do want good information. They need it. They need access to vaccines that can save their lives. And, you know, the headwinds may be stronger, but that doesn't make the job any less important.
Great. Thanks all for a great conversation that we could have without slides, rich as it was. So back to the organizers and then bridge to the next session. Thanks.